Hey guys, welcome back to my channel, The ENT Resident. Today, our topic of discussion is about otogenic brain abscess. You can also now purchase my notes. I have added links in the description. Okay, so what is otogenic brain abscess? Otogenic brain abscess is a localized collection of pus in the brain parenchyma, and this occurs usually as a complication of CSOM or acute otitis media. Now, 50% of brain abscesses that we see in adults and 25% of abscesses that we see in children, they are otogenic in nature. Now, what are the common sites of otogenic brain abscess? This is a very common MCQ question you get in your NEET PG. The most common one is temporal lobe, and second one is cerebellum. So these are the two otogenic brain abscess that you need to know about. Coming to the age distribution, this has a bimodal age distribution with two peaks. The first peak is seen in the pediatric age group, and the second peak is seen around fourth decade of life. Coming to sex distribution, there is a male preponderance over here with a ratio of 3:1. So that's about what is otogenic brain abscess and what are the common sites of it. Next, let's talk about cause. The most common cause of otogenic brain abscess in children is acute otitis media, whereas the most common cause in adults is cholesteatoma. These are two very important MCQs that we need to know. Next, let's talk about what is the route of infection in a case of otogenic brain abscess. If it is a case of cerebral abscess, it usually develops as a result of direct extension of middle ear infection through the tegmen or by retrograde thrombophlebitis, in which case the tegmen will be intact. This is often associated with the extradural abscess that occurs due to erosion of tegmen. This is how it spreads in a cerebral abscess. If it is a case of cerebellar abscess, it usually develops through the Trotman's triangle. In this case, retrograde thrombophlebitis is a lesser known pathway of spread of infection. And again, this is also associated with other conditions like extradural abscess, perisinus abscess, sigmoid sinus thrombophlebitis, or labyrinthitis. So these are the two routes of infection that we need to know about. Next, what are the different microorganisms involved in a case of otogenic brain abscess? Usually, we see a combination of aerobic as well as anaerobic bacteria, but there is a higher incidence of seeing anaerobes over here. So, what are the aerobic bacteria that we see here? They are Staphylococci, Streptococcus pneumoniae, Streptococcus hemolyticus, Proteus mirabilis, Escherichia coli, Klebsiella, and Pseudomonas aeruginosa. The anaerobes which are more commonly seen are the Peptostreptococcus and Bacteroides fragilis. So this is about the bacteriology of otogenic brain abscess. Now let's talk about the different stages and pathological features that we see in a case of brain abscess. So there are 4 stages over here. The first stage is known as the stage of early cerebritis. And this usually is from day 1 to day 3. So what do we see here? Let's look at the image over here. The first image is that of stage 1 or stage of early cerebritis. We see a perivascular infiltration of inflammatory cells surrounding a central core of coagulative necrosis. At this stage, we have very mild symptoms like headache, low-grade fever, malaise, and this usually often goes unnoticed because they are not very typical features of otogenic brain abscess. Now, this moves on to the second stage, which is known as a stage of late cerebritis. This is from day 4 to day 9 of the disease. Now, if you see in the image here, we are seeing that this is characterized by pus formation and it leads to a enlargement of the necrotic center and surrounded at its border by an inflammatory infiltrate of macrophages and fibroblasts. The surrounding area of cerebral edema becomes more distinct. So we see that the central core has expanded and has become necrotic. And the surrounding edema, the reddish area that you're seeing, the surrounding edema has also become more distinct. Coming to our next stage, the third stage, which is the stage of early capsule formation, which is between day 10 to 13 of the disease. Here, now see in the image here, we are seeing that there is a capsule formation happening over here on the cortical side rather than on the ventricular side of the lesion. And this correlates with the appearance of a ring enhancing capsule, which is a very typical feature that helps you in diagnosing the disease when you perform a CT or a MRI. So, at this stage, the clinical features that you will be seeing in the patient will be because of raised intracranial tension, and it will also start to affect the function of cerebrum or the cerebellum depending on where it has involved, and this will lead to the development of focal symptoms and signs in the patient. So, this is when you will start to see the typical features of otogenic brain abscess. This brings on to the last stage, which is known as the stage of late capsule formation, and this is from day 14 and beyond of the disease. Here we see a well formed necrotic center. The yellowish part that you are seeing is a well formed necrotic center, and it is surrounded by a dense collagenous capsule. The surrounding area of edema starts to reduce. If you see here, the reddish area has started to reduce now, but there will be marked gliosis formation outside of the capsule. The enlarging abscess that we see can sometimes rupture even. If you see here in the image, sometimes the abscess can end up rupturing either into the ventricle or into the subarachnoid space, and it can result in a complication which is fetal meningitis. So these are the 4 stages of otogenic brain abscess formation and what features you see in all of them. Now let's discuss about how will the patient present to you with. Now, the one thing that we need to know here is brain abscess, otogenic brain abscess is seen to be associated with other intracranial complications or other complications of CSOM like extradural abscess, perisinus abscess, meningitis, sinus thrombosis, and labyrinthitis. Now, we can divide the clinical features into 2 types. First is the features that you'll see because of raised intracranial tension, and second will be localizing feature, which will depend upon the area of the brain that has been affected, whether the temporal lobe is involved or the cerebellum. Now, first, let's look at the symptoms and signs of a raised intracranial tension. We'll see a headache which is severe and generalized, and it is usually worse in the morning. Nausea and a projectile vomiting will be seen. This is more often a feature of cerebellar lesions. Coming to level of consciousness, the patient will have present to you with lethargy, and this will often progress to drowsiness, confusion, stupor, and finally coma if the patient is not responding to treatment or treatment has been started late. Papilledema is also a feature of raised intracranial tension, but this is more of a late feature when the raised intracranial tension has persisted for 2 to 3 weeks. Papilledema has been seen to be appearing early in cerebellar abscesses. And last of all, we can see a slowed pulse and subnormal temperatures. So these are the symptoms and signs of raised intracranial tension. Now let's talk about the localizing features that we'll be seeing. So first we'll discuss about temporal lobe abscess. First feature here is a nominal aphasia. What is nominal aphasia? Here, the patient fails to tell you the name of common objects like key, pen, cat, bat, etc., but can demonstrate their use. And this occurs when the abscess has involved the dominant hemisphere, that is, the left hemisphere in right handed people. So, first feature is nominal aphasia. Second is there will be a contralateral homonymous hemianopia. This occurs due to pressure on the optic radiation. So we'll see the visual field opposite to the side of lesion is lost. Here we perform a confrontation test where the examiner can stand in front of the patient and compare his visual field with that of the patient. And you can also record this with the help of perimetry. Defect is usually seen in the upper, but sometimes it can also be seen in the lower quadrant. So this is about contralateral homonymous hemianopia, where we see a visual field loss opposite to the side of the lesion, and this occurs because of pressure on optic radiation. Next, we see a contralateral motor paralysis. There can be 2 types of spread. One is upward spread, where a facial palsy followed by paralysis of arm and leg is seen. Second is the inward spread, where there's involvement of the leg first, followed by the arm. Next, coming to epileptic fits. We can see generalized epileptic fits over here. And if there is an involvement of uncinate gyrus, it causes hallucination of taste and smell and involuntary smacking movements of lips and tongue. Last of all, we can see pupillary changes and oculomotor palsy, which is a third nerve palsy. This usually indicates transtentorial herniation. So these are the features of temporal lobe abscess. Next, let's talk about what are the features of cerebellar abscess. So first of all, there will be a headache, which will involve the suboccipital region, and this can be associated with neck rigidity. Next, there can be spontaneous nystagmus, usually seen to the side of the lesion. There's ipsilateral hypotonia weakness, ipsilateral ataxia, where the patient staggers to the side of the lesion. Patient will also have past pointing and intention tremor when you perform the finger nose test. And this diadochokinesia, which is basically when you rapidly pronate and supinate the forearm, patient will show a slow and irregular movement on the affected site. So these are all clinical features that you will be seeing in a case of otogenic brain abscess. Now let's discuss how will we investigate this disease. So the investigation of a choice over here is a CT scan of the brain, which will help you in finding the site and the size of the abscess. And this will also help you in finding out other associated complications. A typical sign that you see over here is the ring sign. See, if you see in the image here, this is the ring sign in the temporal lobe abscess, and the second image is that of cerebellar abscess, where we see a hypodense area. In the center that you're seeing, this area is the hypodense area, and it is surrounded by an area of edema, which is the ring enhancing sign. MRI brain can also be performed. This is usually superior to CT scan because it will help you in detecting even subtle changes in the brain parenchyma and also detects the spread of abscess into the ventricle. We also perform a CT scan of the temporal bone to evaluate the ear disease, and lumbar puncture will also show certain typical features. The CSF that we'll see, usually we do not perform a lumbar puncture in these cases because there is a risk of coning that can happen. But if you had to examine the CSF, it will show a rise in pressure, increase in protein, a normal glucose level, and white cell count will be raised. And depending on whether the infection is acute or chronic, there'll be either an increase in polymorphonuclear leukocytes or lymphocytes. So these are the CSF examination features that you will be seeing. Now let's talk about how will we treat the disease. First treatment over here that is important is medical treatment. So under medical treatment, first of all is intravenous antibiotics. We use usually third generation cephalosporin and chloramphenicol. And Bacteroides fagilis has been seen to respond more to metronidazole. Sometimes aminoglycosides may be required if we are suspecting a case of Pseudomonas or Proteus infection. A culture and sensitivity of the discharge from ear can help you in determining which antibiotic would be best in your case. Other than this, we use certain drugs to lower the raised intracranial tension. So there are two such drugs. If you are using dexamethasone, the dosage is 4 milligram IV 6 hourly. And if we are using mannitol, we use 20% mannitol in doses of 0.5 gram per kg body weight. And discharge from the ear is treated by suction clearance and topical ear drops. So this was about medical treatment. Next, we'll talk about surgical treatment. And surgical treatment can be divided into neurosurgery and otologic surgery. Let's first discuss the neurosurgical aspect. Here, there are three options that we can do. First is we can perform a repeated aspiration through a burr hole and then repeat CT or MRI to see a reduction in the size of the abscess. Second option is we can perform an excision of the abscess. This is done for a case of expanding abscess or one that does not decrease in size. Third option is an open incision of the abscess and evacuation of the pus. Usually, the choice of surgery is totally up to the judgment of the neurosurgeon and depending on what case you have. The pus that you take out is usually sent for culture sensitivity, and after you have aspirated pus, usually penicillin is instilled into it. So these are our three neurosurgical options. Next, coming to the otologic part of it. So, otologic surgery is only performed once the patient has been neurologically stabilized. So, if it is a case of acute otitis media getting complicated, in that case, it usually resolves with antibiotics given for the abscess. But if it is a case of chronic otitis media, in that case, it will require a radical mastoidectomy to remove all the disease and exteriorize the diseased area. So these are all the treatment options that you need to think about in a case of otogenic brain abscess. Last of all, let's discuss about complications and differential diagnosis of the disease. Complications can be ventriculitis when the abscess ruptures into the ventricles, loculation, status epilepticus, sudden respiratory failure, muscular paresis, speech and visual disorders, encephalitis when the abscess ruptures, and septicemia. Differential diagnosis of a case of otogenic brain abscess are subdural empyema, bacterial meningitis, viral meningoencephalitis, superior sagittal sinus thrombosis, and acute disseminated encephalomyelitis. So these are all the things that you need to know about otogenic brain abscess. If you have any questions, please note them down in the comment section and I'll get back to you.